Leslie, who's here with us, will ask us the questions. We have a great distinguished faculty, Matt Gnirke, Scott Raub, and our physical therapist, Sarah Campbell from Avalanche Physical Therapy. I just want to make sure we got everybody before we go. We've actually reached our limit for the number of people we can have in this webinar. We have 100 people participating in this webinar, so I was really excited. That's really exceeded a lot of my expectations. Okay, so let's just talk about what we're going to talk about. So we're going to learn a little bit. I know you guys are bombarded and overloaded with things about the COVID-19 pandemic. I'm going to tell you a little bit about what's going on, how we are adapting to that, and our strategies for the future. We're going to learn a lot about chronic pain, and that's pain that lasts for more than 6 months. Any pain that lasts more than really 3 or 6 months is abnormal and deserves medical treatment. We're going to see what kind of options that you have for your personal type of chronic pain, or if you know somebody or love somebody that has chronic pain, and then discuss how we can make your own appointment. We've got it all set up. We have our schedulers here on the call. So if you want an appointment with myself, with physical therapy, with Dr. Raub or Dr. Gnirke, you can make that appointment tonight. Just use the chat features to make that appointment. Or if you don't feel comfortable doing that, you can always call our office and make an appointment for either in person or telehealth visit. Okay. So the COVID-19 is really caused by the novel SARS-CoV-2 virus. It's a novel virus, meaning we've never seen it before. It's mutated. Most experts or authorities think it came probably somewhere in the East, probably somewhere in China, but it's resulted in unprecedented shutdowns, shelter-in-place orders, and social distancing rules. That's not a surprise to anyone. The folks that are highest at risk are folks that are over 65 years in age, although we know people much younger than that, younger than 20s and 20s and 40s can also get it with very serious consequences. And we know that underlying conditions such as obesity, heart disease, diabetes, or some type of a weakened immune system makes it worse. So it puts gasoline on the fire. So this is all stuff that has been in the news, and you guys have heard this. What's new is we're all talking about these curves, you know, and we want to flatten the curve or one way on the other side of the curve. So, right, this is just the cases in Colorado, and if I do kind of a best fit line, Eagle County's peak was around May 28th, and we're kind of coming down. So that means we'll be able to restart elective surgeries next week. We'll still have enhanced PPE in the office, meaning that your doctors and the folks that work with them will have masks on, and we'll still recommend practicing social distancing in the waiting room. So we'll have only a certain number of people in the waiting room. But we will start seeing elective surgery and start reopening clinic. There have been 488 cases to date in Eagle County, and they have not been increasing over the last 2 weeks, which is a good thing. Similar for Summit County, they have 88 cases, and again, they've been trending downward as well. So let's talk a little bit about chronic pain, what that is. I think of chronic pain, I really start thinking about a problem that's not going away after 3 months. After 6 months, we really think that it might benefit from some type of intervention. Usually, if you're seeing me, it's going to be something minimally invasive. The two main types of pain are going to be mechanical or neuropathic. And mechanical pain usually needs a stabilization operation. It implies some type of instability. That's the kind of pain that you'd have if you had an unstable fracture. But neuropathic pain is that pain that's associated with weakness, numbness, pins and needles. I sometimes call all these terms dysesthesias or abnormal nerve sensations. And the chronic pain is a serious medical condition, and it leads to the following problems. So being able to perform tasks around your home, the ability to be productive in work and socially, the ability to play with grandchildren, outdoor activities such as walking or hiking or recreating, gardening activities or crafts, being sexually active. Chronic pain can stop you from doing all those things. It's okay to ask for an appointment even if you tried some of these other therapies, like over-the-counter medications, physical therapy, TENS units, opioids, narcotics, drugs, previous surgeries, nerve blocks. We still want to see you and see if there's things that we can offer you. Just because physical therapy hasn't helped in the past doesn't mean that it won't help after we do a corrective surgery. And I'm really lucky to have Sarah Campbell from Avalanche Physical Therapy. She's going to introduce herself and tell you a little bit about some of the services that she offers. Sarah?
Thanks, Dr. Braxton. So I'm Sarah Campbell. I work out of our Silverthorne location. And so we have been seeing patients kind of on a regular basis for the last 2.5 weeks now since this whole COVID pandemic, and we're practicing social distancing and mask wearing, glove wearing in the clinic. And then we're also offering telehealth options for patients who are still a little concerned about coming in and maybe just want to talk and see what we have, but we're still offering our normal PT modalities, manual therapy, exercise, all the good stuff that we have to offer in PT. And we're seeing patients out of our Silverthorne and Frisco offices Monday through Saturday. For now, rec patients are being seen in Frisco because unfortunately the rec center is still closed. But like I said, we're still seeing people and getting them in and getting people feeling better. And then we also offer occupational and speech therapy for people who are looking for those services as well. And those are going to be out of our Frisco location with a couple of...
If you guys want a physical therapy appointment, you can just message on text and we'll get you that physical therapy appointment. But thanks, Sarah, so much for kind of going over some of the things you do.
Yeah, thanks for having me.
And Sarah, will you stick around to kind of be on our panel if there's any PT questions that come up?
For sure.
All right, thanks so much. Now we're going to talk about some options that you may not have tried. Radiofrequency ablation, minimally invasive decompressions or surgery, and spinal cord stimulations. I'm really honored to have just a great partner, Dr. Scott Raub. He's been here for over 20 years. I'm going to ask him to introduce himself and talk a little bit about radiofrequency ablation. Scott?
Thank you, Dr. Braxton. So you touched on earlier, I think, a really important point, differentiating neuropathic pain from mechanical pain. And as you indicated, mechanical pain can be things like instability, but the area of radiofrequency ablation really deals with mechanical pain from joint issues. It's different than neuropathic pain, which would be more nerve related. The joints I'm referring to are called facet joints, and you have them in the cervical spine, the thoracic spine, and the lumbar spine. And most of the radiofrequency ablation involves the cervical and lumbar areas where we're treating mechanical pain, which really would be more localized to the back or neck area, more so than down the leg, although I've had people with referred symptoms to their leg or hip area that benefit from radiofrequency ablation, but it's not the classical nerve kind of pain. It is a minimally invasive outpatient procedure, and to get to that point, we have to determine whether in fact you have joint-mediated pain or not, the facet joints, and it can be from arthritis, could be from a whiplash injury. Some people just get it and they don't know why, but we have to do diagnostic injections to start. Sometimes we do injections into the joints to determine which joints are symptomatic, and then subsequently we would, depending on duration of relief, we would then do some blocks to the nerves that we actually theoretically would ablate. And then if that gives you significant relief after 2 rounds of injections that are temporary, then we feel confident that ablating the little nerves that slide depicts, ablating the little nerves that supplied those particular joints using radio frequency energy should help you. It's unfortunately not a permanent solution because the nerves are peripheral nerves and they do regenerate, usually about 10 to 12 months. But it certainly is a reasonable treatment for either back or neck pain that typically is non-radicular or non-nerve related. Sometimes people have a combination of both things, and so we might be addressing the spinal pain component with radiofrequency ablation, and subsequently maybe the nerve pain with different types of injections.
Thanks, Dr. Raub.
This is Leslie too, Dr. Braxton, and we do have a question from someone on the line if it's a good time for me to throw that out there. Gary has asked, is there evidence that joint issues can weaken your immune system and potentially make you more susceptible to COVID?
Scott, I'm going to let you take that question.
Okay. As far as I know, and of course the knowledge of what we have involving the COVID virus now is still in its infancy. Problems with, let's say, spine joints, the facets, or I'd even say the hip joints, usually be an inflammatory issue. It should not really enhance or cause you to be more susceptible to developing or getting COVID or perhaps having a more severe viral infection. So I don't think the two would be interrelated in that way.
Any other questions, Leslie?
I haven't gotten any yet.
Okay, well, let's move on to Dr. Matt Gnirke. He's another New York native. He's going to talk a little bit about himself and about biologics. And then, hey, Dr. Gnirke, can you just tell me when you want me to advance your slide?
So let me unmute here to start. Good evening, everyone. My name is Matt Gnirke. I'm the newest physician at Vail-Summit Orthopedics and Neurosurgery. I'm just finishing up on my first year here with the practice. And I wanted to start just by saying thank you very much for having me along tonight. And as a new member of the medical and greater community here in Eagle and Summit County, it's been really great. I truly appreciate the opportunity to be here. As you can see, I'm from New York and I've trained all over. I went to undergrad at Virginia Tech, med school back up in New York, and completed my residency training down at the university in Denver. And then recently was in fellowship in Napa, California, which was a great year. And so I'm going to just really briefly introduce biologic treatments for pain, and you can advance the slide, Dr. Braxton.
All right.
See how this teamwork works here. Perfect. So biologics are really an emerging area of treatment for various painful conditions. This is really a full topic in and of itself that could certainly fill an hour or two or a weekend seminar, or in my case, a full year fellowship. So I'm just going to really hit on some of the highlights and happy to talk about these treatments in more detail if there's any general questions from the audience tonight, or on a case-by-case basis if folks would like to come in and chat with me in clinic. So when we talk about cellular treatments or biologic therapies, they fall generally into two major categories, and there are some other products out there as well. What I use most commonly for most conditions is platelets or platelet-rich plasma, as the platelets are suspended in your plasma. And there's also a burgeoning field of quote-unquote stem cell medicine that involves various types of cells, some of which come from your own body, be they from your bone marrow or adipose tissue, or allogenic products such as placental tissue and cord blood. There's pros and cons to each of these depending on what exactly we're treating, and happy to get into some of that if there's some specific interest. We can go ahead and advance the slide. When we talk about what are these treatments used for, it's really a growing, there's a growing body of evidence for various diagnoses where biologic treatments are helpful. Most commonly, I'm using these to treat arthritic type pain related to knee, shoulder, and hip arthritis, tendon-related disorders such as rotator cuff tendinopathies or partial thickness rotator cuff tears, Achilles tendinopathies in runners very commonly. I also treat low back pain with biologic treatments, specifically for discogenic pain or arthritic pain related to the facet joints, the same joints that Dr. Raub spoke about with the ablations. There's a growing body of evidence for the use of these treatments for peripheral nerve related issues. Unfortunately, they're not great for spinal stenosis, which is one of the more common diagnoses that the physicians and Sarah treat. And I think Dr. Braxton is going to talk about some of the more advanced, minimally invasive techniques that he has for that specific diagnosis. We can go ahead and advance there.
Dr. Gnirke, before you move on, we do have a question if you're ready for it.
Sure.
John asks, are stem cells prevalent in all humans regardless of their age?
Sure, so they are certainly present in all humans, regardless of their age. They tend to be less numerous and less effective as we do age, as our telomeres shorten and other cellular aging processes take place. And so in short, yes. In long, it's complicated. So to talk about, well, how do I actually deliver these treatments? I use quite a bit of musculoskeletal ultrasound in my practice. I'm a certified musculoskeletal ultrasonographer. This is an ultrasound image of a patient of mine with a partial thickness articular surface rotator cuff tear. And you can clearly see that dark spot in the distal tendon where the tear is, and the arrow indicates the needle trajectory. So we can precisely deliver these treatments directly to the site of pathology with the use of ultrasound. And we can go to the next slide. It's my last slide, just to say that since I joined the practice, I was able to set up a lab at each of our locations in Frisco, Vail, and Edwards. So these treatments are available in a clinic setting at all of our practice locations. So happy to talk about any further questions or pass it back to Dr. Braxton.
Yeah, this is Leslie again, and I do have another question from Dan here. Actually, I have two questions. I have one from Mark. He was the first one. It says, how many of these STEM therapies are covered by Medicare?
Yeah, so these treatments are considered investigational through the FDA. And so as part of that investigational denotation, they are not covered yet by the large public insurances. The wave of insurance coverage is starting. So work comp insurance will cover it for selected diagnoses. Kaiser, which is a closed health system, has started to open PRP clinics as they found it to be quite effective and cost saving in that closed system. So unfortunately, Medicare does not yet cover these treatments. That may change over time, and we're looking forward to it changing.
I got another question from Dan. He said he's had 2 disc surgeries, L5S1 and one at L4-5. L4-5 was 3 years ago. He's had numerous injections and all have been dead ends. Forward left foot remains numb consistently, some days worse than others, but always there. Are there any other advancements of interest?
L4-5, that's me.
Yeah, so that's getting into some specifics about Dan's medical history. I'd be happy to chat with him in great detail in a confidential setting. Certainly to answer this question appropriately, you'd have to review the current imaging, old imaging, what surgeries were actually done, and what previous injections. So there certainly may be some additional treatment options. It would take some detailed investigation into what has already been done, and I'd be happy to help with that in the clinic setting.
Okay, and then we had one more question, and I'm not sure if this is specifically for you, Dr. Gnirke, or just for the physicians in general, but it is asking if they have Medicaid, if any of these different treatments y'all are talking about are covered.
Sure. So Medicaid patients, certainly Medicaid, Medicare, private insurance, really all comers in my personal clinic. There are several treatments available to patients with Medicaid, Medicare, and et cetera. The biologic treatments are not covered by that public payer source, but there are certainly more conventional treatments that absolutely are covered.
Yeah. Dr. Braxton and Dr. Raub, do you have anything to add to any of those questions?
So, as Dr. Gnirke correctly said, these are newer treatments are not covered by folks that are federally insured, and that's Medicare and Medicaid, but they are very affordable treatments, many of which can be done in the office without having to go to the surgery center. Dr. Raub?
Well, the radiofrequency ablation procedures do have to go to the surgery center. And I do take Medicare patients. I don't think I'm enrolled in Medicaid.
Okay. And then there's just one more question for you all, and this is just any recommendations on mattresses, for instance, the purple bed. Do you guys have any recommendations for any of those that are suffering with chronic pain?
I've heard a lot of good things about the purple mattress. I think it really comes down to personal preference. In general, firmer mattresses tend to be a little bit better, but it really comes down to personal preference. I tell my patients, if you can sleep in any position you want, if you're a vampire, sleep upside down. If you like the purple mattress, go for it. I've heard good things about it. I've never, it's not been studied in any kind of clinical way, but if you like it, go for it. But I don't have like a scientific or medical recommendation for the type of mattress. In general, firmer mattresses tend to be better, but it's all personal preference.
I would agree. I don't think that there's ever been a study to show superiority of a specific mattress brand or type. I think conventional thought is that the firmer the better. I've personally tried, I think, every mattress from Tempur-Pedic to the one that you fill up with air. I can't think of the name of it right now. I think firmer is better. I use a hybrid mattress. I find that that's a good combination of firm and filling in some of our natural curves, but there isn't a right mattress.
Yeah, the only one I know that you fill up with air is the air mattress, and that's like for guests. But I'm going to talk a little.
I'm talking about the fancy one that you dial up the number, sleep number.
Okay.
Yeah.
So this is a therapy that is medically necessary and covered by all major insurers, including federally insured folks. It's called MIS decompression. It's really one of my favorite operations. The question is, have you ever felt this way? Pain with walking or standing is really the critical part of the history for neurogenic claudication, which is what I'm talking about. And the question I like to ask folks is, when you're out shopping, does leaning over a shopping cart help? Or does sitting down temporarily relieve your symptoms? If so, you may be suffering from neurogenic claudication. I always joke that if I have a light week, I'm going to go to Walmart and look for people leaning over the shopping cart and hand out my business card and see if I can help them. But it is a serious problem. It's very common as you get older. What happens is the area around the nerves gets crowded with arthritic changes. When there's this pinching on the nerve, it decreases blood flow and nutrition to the nerves, and it results in this claudicating pain, or this pain that's worse with walking and standing. It may be in your back, it may be in your leg, it may be on both sides. It's that dysesthetic neuropathic pain. There's a lot of different treatments for this. I prefer minimally invasive decompression to do this operation. There's also implants that can be put in to open up the space. We're going to talk mostly about minimally invasive surgery. So minimally invasive surgery is designed to achieve the same results as open surgery, but with faster recovery because we're not disrupting the muscles as much. These operations are performed awake without general anesthesia with very small incisions. Most people go home the same day. In fact, I'd say 99% of all people go home the same day. There's very low risk of infection or complications, and it can provide significant long-term relief. Although, especially if there's another condition, pre-existing condition called spondylolisthesis or instability, resulting in mechanical pain, that's something we talked about a little bit earlier, there is a risk of reoperation in some studies up to 30% in 3 to 4 years. So if you're willing to take the risk of reoperation, if you have a spondylolisthesis, I think this is a great option. I have a patient who let me film him in the operating room. We have his face blurred out, but he said he didn't mind, but I decided to blur it out to protect his privacy. And it just shows you the benefits of being able to have this surgery done awake. It's faster recovery, ability to monitor the patient's neurological function during surgery, and it eliminates the risk of general anesthesia. And I think it creates a more patient-centered environment, a better environment where The patient picks the music. I don't pick the music. The team doesn't pick the music. I'm just going to show you this one video here. So the patient's face is kind of blurred out just for his privacy, but he's wide awake during the operation. And we do have some people with some anxiety. We can make you a little bit sleepier if that's what you prefer. But in general, folks are wide awake. The area where we operate gets all numbed up, and they don't feel any sharp pain. They might feel a little pulling you're talking, but no sharp pain. And oftentimes they feel better right on the operating room table. Next question.
We have a couple more questions if you're ready for them.
Yeah, go for it.
So Kathy is wondering what treatments are effective for treating neuropathy in legs and feet?
Okay, so peripheral neuropathy, it sounds like what you're talking about. There's medical treatments, gabinoids such as Gnirke, gabapentin often treat that. You have to remember that there's no cure for peripheral neuropathy, just treatment. If there's an underlying cause, such as diabetes, getting the blood sugar under better control can help treat those symptoms. Some folks have found relief with certain types of creams, such as capsaicin. A higher level treatment would be what we're going to talk about next, and it's a perfect segue, is spinal cord stimulation. So spinal cord stimulation, hold on one second while I get a little situated. Spinal cord stimulation is for neuropathic pain. It doesn't respond as well to mechanical pain like a broken bone or an unstable fracture, but it does does a great job on neuropathic pain. It can be used even if you've had a previous fusion by another doctor or even by me. If you have what we call failed back surgery, it can be very effective for treating pain in your back, legs, or feet. So, and then there's a certain special category of pain we call complex regional pain syndrome. The old name for it is reflex sympathetic dystrophy, where you have very severe pain, usually after a broken bone or a surgery that is quite severe. So SCS is considered when medications or surgery are not an option. When generally you've failed other things like radiofrequency ablation, physical therapy, epidural injections, and still have pain, then we can consider you for spinal cord stimulation. Spinal cord stimulation has actually been around for quite a long time. It's come in different generations. The latest generation we show here is FDA approved. It's not a drug therapy. It is kind of a pacemaker for the spinal cord, so to speak. And it also has been shown to reduce oral drugs and their side effects once it's if it's successful. Most are covered by most insurance plans, including Medicare and most workers' compensation programs. So we're going to talk about some of the newer programs and living with the spinal cord stimulation in the next slide. But as I said, it's a pacemaker for the spinal cord. There are therapies that are subperception therapies, meaning they work in the background to block your pain. And there are other programs that actually block your pain just with you feeling kind of what I call champagne bubbles, this kind of buzzing sensation that kind of blocks the pain. It's kind of like if you've ever stubbed your toe or hit your head, inadvertently hurt your thumb with a hammer. You don't have to go to medical school to know that it feels better when you rub it. That other stimulation blocks the pain. And you can think of spinal cord stimulation is a form of gating, although the true entire mechanism isn't entirely understood. What we do know is that it's effective at reducing pain in well-controlled studies. So everybody that gets the spinal cord stimulation operation is a two-stage operation, meaning that the first stage you get the leads implanted, and then I have to ask you, does it help you? Does it work? And you're the only one that can answer that question. But some things to look out for is at least 50% improvement in your pain. If you're able to get back to your daily activities, if you reduce the amount of pain medication that you take while you're getting spinal cord stimulation, and if you have better sleep, whether it's on a purple mattress or on a sleep number bed or Tempur-Pedic. If you get better sleep with SCS, it might be a sign that you're ready for a permanent implant. Spinal cord stimulation, as I said, can be paresthesia-free or combined with paresthesias. And the paresthesias are those champagne bubbles we use to block the pain. The device is something that you control yourself with a remote control. And depending on the type of generator implant, you may have to recharge the device just like you might have to recharge your phone, your iPhone. Those well-studied trials that I was talking about show a sustained reduction after 2 years with spinal cord stimulation, with most people going from an average of 8 out of 10 to 2 or 3 out of 10 after pain. This doesn't make all your pain go away, but it helps make you more functional. Occasionally we hit what I call those home runs where you're completely pain-free, but my goal is to make you more functional. So if you're experiencing chronic pain, you can't participate in activities of daily living, you can't recreate, play with your grandchildren, get out and garden, or even have sexual activity, you may want to look into a spinal cord stimulator, and you may still be a candidate even if you've had previous surgery or other treatments have failed for you. So the next step is to kind of meet with us on an individual basis. Dr. Gnirke had a very specific clinical question. I would encourage that patient to make an appointment with Dr. Gnirke. And if they want, they can just reach out either by calling our office or visiting vsortho.com. My website is Braxton MD. And for more detailed information, you can go to controlyourpain.com. In doing so, you can make an appointment. You can even make an appointment here tonight if you just want to private message Susan Flock or send one out to the group and she'll reach out to you and get you an appointment tonight. So with that, we're going over a little bit on the amount of time that we're supposed to have for this meeting. I was overwhelmed with the number of people that we had. I'm going to close the slideshow and ask our panelists to take a few more questions regarding anything they heard in this talk. But like I said, we're already over time. We maxed out at 100 participants. So I'm really excited, but we'll just take a few more minutes to field some questions. So if the panelists can turn off, unmute themselves, and I'll stop the slideshow.
I have a couple other questions that have come in. Oh, let me try to find them again. One was, let's see, I apologize. How would you accomplish a decompression on someone allergic to topical anesthetics?
Well, that's a topical. So we don't use topical anesthetics. We use injectable anesthetics like lidocaine or Marcaine to do it, to do the decompression. We could always do it under a general anesthesia where you're going all the way to sleep. That's probably the easiest way to do it, would be to do it under general anesthesia. It's quite rare to have an allergy to something like lidocaine or Marcaine, but if you do, we could just put you all the way to asleep under a general anesthesia and then get the IV medications and still do the decompression. We also could take like a big stick or wallet. You can just bite on it during the surgery. That's a joke. I wouldn't do that.
I have a couple more questions. One question is, what additional measures are being taken to avoid the spread of COVID at the surgery center?
So that's a great question and very topical. So we're doing what's called enhanced PPE. Have you guys all heard of PPE? That stands for personal protective gear. So from the get-go, everybody in the facility will be wearing a mask. We also will offer testing to folks that we consider higher risk. And hopefully in the future be able to offer testing to everyone that goes to the surgery center. And then while you're in the operating room, the anesthesiologist will have those special N95 masks. You know they're in short supply, but we have a bunch of them for our surgeries. Another thing is we keep you kind of separate from the rest of the hospital. We have two main surgery centers in Vail. The Vail one is temporarily closed. We've decided to use the time for some remodeling, but the Edwards is on a separate campus and totally separate from all the patients in the hospital. And the hospital has very few cases. Will Cook just made an announcement that, Will Cook's the CEO of Vail Health, that there were only 2 patients and one of them was leaving today. So there's very few patients who have COVID in our community. But enhanced PPE measures and testing are the mainstay, and then reduced visitors. And the other thing is you're going to get screened. So if you do have COVID symptoms or have been in contact with anybody with COVID symptoms, we're going to ask you to wait until you get over those symptoms. Did I answer your question? Any more questions? We have a few more minutes for a couple more questions.
Yeah, there's just a couple more. This patient had an ACDF in January and still not fused in one area, has constant pain on the right side of neck and runs along the top of the shoulder. Wondering what they can do for that.
I'm going to answer that question in very general terms. So if he's not fused, then that could be causing the problem. You might need a revision surgery. There's also medications, but I would encourage that patient to make an appointment with me. So with the films, I really, to answer that question more intelligently, I'd have to look at the x-rays and the films to get more of a history. But one solution might be revision surgery, either from the front or the back. We try to do it as minimally invasive as possible.
Perfect. And just one last question came in, and it was just asking, is imaging available on Summit currently with everything going on with the virus?
Absolutely. We have x-rays as well as an MRI in our office over in Frisco, which is in Summit County. That's totally open. They do have some reduced hours, but we are gradually bringing that back online. Also, Summit Medical Center is open for imaging as well. If you're okay with going to the hospital. But in our clinic, we have imaging modalities. Ultrasound can be, if it's musculoskeletal ultrasound, that can be performed. Dr. Gnirke, can you comment on ultrasound in Summit?
Yeah, so we have ultrasound capacity in all of our locations. Happy to help with any diagnostic ultrasound exams that would be helpful for patients. Commonly look at shoulders, hips, knees, ankles, and everything in between. So happy to help with that. It's real-time imaging, so the patient can see it along with me, and we can do some dynamic testing, which is unique for ultrasound as well.
Any other questions?
Add one other thing regarding pertaining to the question in this environment of the COVID-19. This came up yesterday. We do wipe down the MRI scanner thoroughly. I had a patient that literally asked me that yesterday. So we are doing that as well for the MRIs.
Wow. I'm kind of, on my screen here, I'm looking at this huge Brady Bunch view of everybody out there, and I'm just so overwhelmed about how many people are tuning in. If this works for you guys, we can continue this series maybe once a month or more frequently on other topics like artificial disc, on sports medicine, on hand, and so on. So we'll just try to stay in touch. I did have a meeting that obviously had to be canceled at Castle Peak, and this is my way of still getting out to the community and reaching out and answering questions. So, I see another question about scoliosis. Yeah. So scoliosis surgery is something that I did some of in the military. It requires a little bit more intensive care than we can offer up here in the mountains. Oftentimes with scoliosis surgery, if it's a big deformity for a young person, they might need, ICU care and ability to transfuse blood. I prefer, and I know what I'm good at, I prefer to just do the minimally invasive stuff. I do have a lot of great friends in Denver, New York, and San Francisco that I can refer you guys on to if you have a question for scoliosis. We can call our office and we can get you a referral for somebody that specializes in deformity. I try to stick with minimally invasive. Scoliosis surgery generally is not minimally invasive. It's a bigger cut and bigger correction. But each case is individual. If it's just a degenerative scoliosis, if you're older, that's something I can take on up here in the mountains. But if it's a big 20 degree curve or more, I probably would send you to Vic Patel, Larry Linke, or Praveen Mamanetti, one of the people that specialize in scoliosis surgery.
In terms of PT, we can help with a lot of the kind of functional impairments or pain modification and kind of reduce some symptoms that way.
All right. Well, thank you. We're over time, but thank you guys so much for all your great questions.